Okay, this is going to be on a pretty actually complicated concept in genetics known as imprinted disorders. And I know we've talked about a lot of things so far, inheritance, chromosomes, things like that. But there are a number of reasons for a gene product not to be working correctly. One is a deletion of the gene. Another is a mutation or sequence change in the gene that makes the protein. And then the third, and we've talked about the first two, is a methylation or turning off of the gene. So it's there, it's sequenced correctly. So if I sequence it, it's sequenced correctly, but it's turned off. And so we can't translate it and make a protein from it. So these are known as imprinting disorders. In order to make a gene product, we have to make mRNA, so the promoter has to attach and make the mRNA, so it attaches to the promoter region and makes a copy. It goes out into the nucleus and is used as a template to make a protein. But if it cannot be activated because it's methylated, then we make no copy of the gene. Again, the sequence A, T, T, G, whatever is completely normal, but it's methylated. As a result, we do not get a protein product. We don't get the end product. Now, the X chromosome, females have 2 X's and one is completely inactivated or methylated. Well, not completely, but the vast majority, or known as imprinted. So there are approximately 80 known imprinted disorders, probably more. When I went to medical school, we knew about 2 genes, and every day I learned about a new disorder that I never heard of in my life. So right now we say there's 80, and we also think it might be important in cancer and things like that. This allows limited dosage of the gene product. So in most cases, we have 2 copies of our gene, one from mom, one from dad. It both makes the product. But there's certain genes that you can only have a certain amount of protein or product, and so either the maternal copy's on or the paternal copy's on. So in some disorders, the maternal copy of the gene is methylated or imprinted or turned off. In other disorders, only the father's copy of the gene, the father's copy of the gene is methylated or imprinted. While most imprinting occurs during oogenesis and spermatogenesis, we're again realizing that during an individual's life, this can occur and sometimes can even be passed on to the next generation. I'm not going to be going into all those details, but I'm just giving you a taste of what things might change as you practice medicine. Obesity is thought to be one of these type of genes, although we don't really understand obesity genes very well at this point. So common imprinted disorders that I want to talk about, we've already talked about the clinical characteristics of Prader-Willi and Angelman syndrome, but I'm going to talk about them in the perspective of imprinting, and then the other one is Beckwith-Wiedemann syndrome. I am not going to ask you questions about Beckwith-Wiedemann syndrome. However, it's not on the objectives, it's not going to be on the exam, but it could be on STEP. So, Prader-Willi syndrome, we've talked about this before, 70% result from a deletion of the SMP gene on chromosome 15q11 region. Features include failure to thrive in the newborn period. Here's this kid with the NG tube, really thin, followed by obesity, low muscle tone, small hands and feet, and mild to moderate cognitive delays. Angelman syndrome, 70% result in the deletion of the 15q11 region. And this is actually a different gene, the UEB3A gene. Features of Angelman syndrome include severe postnatal growth deficiency. They don't have the failure to thrive that Prader-Willis do. They're always usually below maybe even at the first percentile, but they kind of grow along their growth curve. So a lot of times they actually come to medical attention a little bit later than the Prader-Willis, because the Prader-Willis just fall right out. They're not eating. They can't date. They have such low muscle tone. They're not able to feed, and they fall off the growth curve, whereas Angelman's always kind of, they're growing, but along their horrible growth curve. But they do have failure to thrive, very severe cognitive delays, IQ around 40, absent or limited speech, a puppet-like gait. We used to call this the happy puppet syndrome. They've, again, gotten away from naming things like this. But I just want to, this little girl is very ataxic, and the way her hands are up here. They have paroxysms of inappropriate laughter, but it's not actually laughter. And again, I've had kids with Angelman come to medical attention later than kids with Prader-Willi. And everyone's happy because when they're 3 or 4 months, they're like laughing and giggling. And around 9 or 10 months, people realize the baby's not laughing or giggling. It's more like a reflex. It's not actually in response to somebody making a funny face or something like that. They have seizures and very poor sleep patterns. Sometimes they don't go to bed till 2 or 3 in the morning. They're very disruptive. One of the questions I always ask is about sleep with some of these syndromes. So, the genes associated with Prader-Willi is SNRPN. And this is only active when it comes from the father. And the gene associated with Angelman syndrome is UEB3A. And this is only active when it comes UBE3A. Yeah, when it comes from the mother. So, here's the dad's copy. The SNRPN is on, the UEB is off. In the mom's, the SNRPN is off and the UBE3A is on. Now, these are imprinted genes. So one of the most common ways that this happens, especially in Prader-Willi, is something called uniparental disomy. And I have to be honest, when I first heard this concept, I thought this was the most ridiculous thing, that this couldn't happen. So here is the dad's copy of 15, and here's the mom's copy. Okay, and here's meiosis 1 when the chromatids are supposed to separate. Excuse me, the chromosomes are supposed to separate, but they don't. So both 15s go to this side, and then the chromatids separate. And so there's 2 copies of 15. Both come from mom. So here's mom's, dad's copy, mom's copy. And these are both methylated off. And this is another thing. During oogenesis, the dad's copy, the mother's copy of 15 that she got from her father, has been on all of her life, and then she shuts it off during oogenesis. We're not 100% sure how this happens, but it happens. So she gives 2 copies of chromosome 15, and in comes dad's copy. His is on, these 2 are off. Trisomy 15 is incompatible with life. So the cell says to itself, one of you guys has to hit the road. So if it kicks off this copy, we have a copy from dad that's on, copy from mom that's off, we're good. If it kicks out this copy from dad that's on, copy from mom that's off, we're good. But what if dad's only contribution is the one that's excreted? Now we have 2 copies of chromosome 15, and they're both methylated off. And as of today, we have no way to turn it back on. Maybe if we sometime learn how to do that, that would be a treatment. But right now we don't. And so about 30% of kids with Prader-Willi end up here. And yet, of all the trisomy 15 conceptions, 2/3 of them don't end up with Prader-Willi because they excrete one of mom's copies of 15 and keep one of dad's copies. And then here, what about this cell? When the chromosomes separated, we didn't get anything. And so we got all the other 22 chromosomes, but there's no copy of 15 contributing from the mom. So dad donates his, so there's only 45 chromosomes, so dad duplicates his. Well, what's the problem with that? Well, we have the Prader-Willi on, but what do we have off? The Angelman. A small percentage of kids with Angelman have this. Isodisomy is it's the same chromosome that duplicates. Heterodisomy means it's mom's copy and mom's dad's copy, so it's heterodisomy. So, 70% of patients with Prader-Willi have a deletion of the paternal copy of the SNP gene. So here's the critical region. About 70% of the time, dad's copy in the blue is deleted. About 28% of the time, both copies come from mom, as I was showing you in the last slide, the UPD. And then about 2% of cases, what if dad's mom's copy he can't turn back on? So he has to turn his mom's copy back on. What if that gene doesn't work? About 2% are methylation defects. And if this is the case, there's a 50% recurrence risk. But fortunately, it's a very, very rare cause of Prader-Willi syndrome. Let's look at Angelman syndrome. 70% result from a maternal deletion of the UBE3A gene. Okay? About, 68 to 70%. About 7% result in isodisomy, both copies coming from dad. About 3% are an imprinted defect. Mom can't turn back on her dad's copy of this gene that was off all of her life. And then about 11% there's actually a mutation of the UBE3A gene. So this actually doesn't happen as much in Prader-Willi, but in Angelman, about 11% of the chance it's a mutation. And again, this is the only one with a recurrence risk. So if a patient is noted to have a deletion of 15q11 by either FISH or microarray, does the patient have Prader-Willi or Angelman syndrome? And one of them, you put together the clinical characteristics along with the genetic results. So if I had a 3-year-old with obesity, food-seeking behaviors, and this deletion, I would say, well, based on the clinical presentation in this deletion, that's Prader-Willi. If I had a 3-year-old with no verbal speech, autistic, and there's a deletion of this region, I'd say, well, you put this together. This sounds like Angelman syndrome. However, what do I do with a newborn that has a deletion? Is it a newborn with failure to thrive? Is it Prader-Willi or is it Angelman? And I don't know. And it actually is important to know. So what we do is we look at the methylation pattern. So we should have a maternal and paternal methylation pattern. If all we have is a paternal methylation pattern, either the mom's copy was deleted for this region or both copies come from dad. And if we only have a maternal pattern, then either mom's copy is deleted or both copies come from dad. So with Prader-Willi, we only have the maternal copy or maternal pattern, and with Angelman, we only have the paternal copy, and normally we should see both. So this is like if I have like a FISH or deletion, microarray, whatever, that there's a deletion, I then have to do these methylation studies. Now, again, the next thing I want to talk about is Beckwith-Wiedemann syndrome. This is not on the exam, so I put it in red. If you want to shut off this presentation right now, it's fine. It's a disorder of overgrowth. Features include increased birth weight, hypoglycemia. They can have an umbilical hernia, and a really, really big umbilical hernia is an omphalocele. Normally, the intestines go into the umbilicus. They kind of turn and come back in. They don't come back in. They stay. It's membrane covered. They have a big tongue, macroglossia, and one side is bigger than the other. Sometimes they also have this unusual birthmark. This is called the glabellar hemangioma. It gets really red when they start screaming. This is a complicated disorder, but it really has to do with methylation and control of growth. So there's an abnormality in the balance of growth. And there's a complex located on chromosome 11. And in normal circumstances, the maternal chromosome has, with the KCNQ1 gene, is methylated, but the IGH is working. So this one's off and this one's on. And the dad's copy, this one's on and this one's off. So this is how we control growth. But any combination, if both copies of this are both working, we have too much growth. If we methylate both, we don't control growth. If both copies come from dad, then we have the double whammy of this UPD. We have both of these on and both of these off. Or if there's a mutation of this KD CDKN1C gene. All of these can result in abnormal growth. You only need to know what you really need to know about Beckwith-Wiedemann syndrome, as it increases growth and it's a methylation abnormality. It's inherited and autosomal dominant and occurs in about 1 in 15,000, but 1 in 4,000 of babies from in vitro fertilization. For whatever reason, and we don't understand it yet, methylation defects seem to be more common in babies conceived by in vitro. In addition to the risk of birth defects such as the macroglossia and the omphalocele, they're at risk because of this abnormal growth of abdominal tumors, including Wilms tumor and hepatoblastoma. Approximately 5% of babies with Beckwith-Wiedemann syndrome will develop Wilms tumor. And the thing about Wilms tumor is, and I know you've had, well, actually next you'll have your oncology thing, so we haven't gone over that yet, but Wilms tumor diagnosed in stage 1 is a pretty decent prognosis, and in stage 4 not so much. So what we do is a renal ultrasound every 3 months till age 8, and then there's a liver tumor known as hepatoblastoma that we look at a primitive liver marker called alpha-fetoprotein, which should actually, it's high when the baby's born and it kind of decreases over time, but if it starts going up, it's a sign there could be this primitive liver tumor known as hepatoblastoma, so we measure that every 3 months till age 3. After 3, there's never been a case of hepatoblastoma. Usually it's after 1, but we, use statistics. And renal ultrasound, we used to say till age 6, and now we say till age 8. So this is, I found a USMLE question. So a 1-day-old female is admitted to the NICU with an omphalocele. She has a large tongue or macroglossia. The birth weight is 5 kilos, so a really big baby. She's noted to have loss methylation of the KCNQ1 gene. What is the most likely diagnosis? Prader-Willi syndrome, Beckwith-Wiedemann syndrome, Villus-Carter-Fischl syndrome, or Down syndrome? And the answer is Beckwith-Wiedemann syndrome. I'm actually going to change this from methylation to mutation of this gene. Anyway, that concludes this presentation. So imprinting genes are genes that only one of the 2 copies is active. We know about 80 imprinted genes. This is known to be associated with cancer, but we don't really understand it that well yet. And over time, we'll continue to understand the importance of imprinting in genetics.